Okay. Ça va? Ouais. So, thank you to be here tonight and to have chosen to hear about abortive pill rather than the presentation in Institut Français about the NIPA. At what time? 6. So, I am Pascale Hancart Petitet, an anthropologist from IAD, Institut de Recherche pour le Développement. It's a French public institution. And the work I will present today is related to 4 years of postdoctoral research I was conducting here in between 2008 and 2012. And I came also here today because in 2008 I founded this human science encounters in Phnom-Penh, and since it has grown a lot, and now we have quite 1,000 members in the network. We will through that our information, our newsletters, monthly newsletters, and here we have roughly one conference per month, and here in this university, and we are very thankful to His Excellency Mr. Bongsovat, the rector of the University of Fine Arts, to welcome to the conference since 4 years already. So, so I will speak about this one. I work mostly on human reproduction issues, and you will see that it's lead very much to work at different level of analysis, from the body, the person, from the society, but also from a local to very global level. So it is true that ways that I think the abortive pill practice issue, I really try to give a mirror view actually on those abortive pills. Alors, I will read this paper, but for this presentation, as it is on Prezi, if you want to come up with it, it's easy to find when you type the title, and we can have all the pictures I wanted to show you tonight. It's really a pity. So I would like to explore the complex trade-off between the various actors at national and transnational level that shape the diffusion and the regulating process of abortive pill, mostly in Cambodia, and maybe I will talk about Laos at the end. So the regimen of abortive pill that combine the mifepristone with the misoprosol, two molecules, is validated now in many countries, but abortive method has generated various debates. So before to start to speak about Cambodia, I felt it was very much necessary to speak of the creation of this abortive pill. So it was the mifepristone, known as the RU 486 in France, was developed by the French company Roussel-Uclaf in 1980 and developed by the Professor Beaulieu, and it was marketed on that time as a branch name mifegine. And this molecule was presented in the Academy of Science in 1982, and it was really much presented as an alternative of surgical abortion. So the scientific world was very much interested by this discovery, and quickly Roussel-Uclaf signed a contract with the WHO, the World Health Organization, within the American NGO Population Council. But in France, this event provoked very strong reaction, and also in United States. So the marketization of RU 486 went to various clashes. And in mid-1980s, the French pill was nicknamed the death pill or the human pesticide, in particularly by the pro-life movement, the movement against abortion. And finally, in 1989, the Food and Drug Administration lists the molecule among the prohibited import products. So then it takes years, and it was only in 1991 that regulation came, and in 1997, FDA approved the product to be put on sale. So unlike many countries where years of negotiation were needed for this medication to be available in pharmacies, the penetration of the RU 486 in China was very rapid. And in fact, at the beginning, the pharmaceutical company Roussel-Uclaf refused to sell the molecule to China, arguing about the weakness of health services. But it was quickly copied by the Beijing authorities and was available in China around 1988 after several clinical trials. So how do the abortive pill arrive in Cambodia? The emergence of the black market of the abortive pill in Cambodia is very much difficult to date. So mifepristone has probably been available. It has been available in 1998, but we can guess that the penetration in Cambodia has been very rapid, given the entry of products from the pharmaceutical industry into the Cambodian territory. Was not new, and it has already started under the French protectorate, and also considerably augmented after the Pol Pot regime and during the Democratic Cambodia. So during this period, private pharmacies were officially banned, although there were still numerous establishments by Chinese, Sino-Cambodian traders. So the first license given to pharmacy went around 1988. I refer to the work of Overson and Tronkel on that. And then, with the arrival of the UNTAC, the United Nations Transitional Authorities for Cambodia, and the openness of Cambodia to the liberal market, a large quantity of drugs were sold by pharmaceutical companies. But under these drugs, I will not go in details, but there is a different variety of drugs, mainly antibiotic and anti-malarial, that are from the counterfeit medicine or illegal importation. What we call the Chinese pill, the abortive pill made in China, is one of these drugs known as the non-registered by the Cambodian Ministry of Health. So before to go deeper in this analysis of Chinese pill, I thought it was very much relevant to give some information related to the context of birth control issues in Cambodia. Effectively, since last 30 years, the maternal mortality has very much decreased, and also the fertility rate have also considerably decreased, and it is very much related to the various programs that have been implemented here about birth control and the reduction of the maternal and child mortality. But what has been also documented is despite the availability of birth control methods, still many Cambodian women do not use this method or switch to a method to the other one, and abortion also is very much used as a birth control method. I wanted to show some reference of publication here, but if you Google abortion and Pascale Hancart Petitet, you will find different publications I document on this particular issue. So the abortion market is quite developed in Cambodia in different settings, and various kind of health practitioners provide abortion services, both trained and non-trained, in various biomedical settings. And there is also various illicit abortion practices by curettage or aspiration that are made by health workers that are trained or non-trained person, and it depends. There is different services at various costs, and for sure that the lower costs are mostly also the most at-risk practices. At the time when I was conducting the fieldwork on that, I did ethnography of some practitioners that were providing abortion services at their home. So they were showing me their material of curettage especially, and of MVA machine. On that, I published also a paper about the risk of reproductive health practices in various biomedical settings. So, and various studies have documented Cambodian women experience in accessing in traditional non-surgical abortive method, and I refer to the work of Oban and Ratavi. And for example, beside this Chinese unregistered pill, there is also various products that are developed by Cookmer, for example, or that are developed by the Yeimab, the Matrol, and they have various recipes made by herbs mixed with some tablets from the biomedical system to be used as abortive practices. So in Cambodia, there is various also actors that are providing those Chinese abortive practices. They are effectively, those pills are made of mifepristone and misoprosol, but there is different combination, different dosage that are not always following the international recommendation on that. And that are also the cause of incomplete abortion or not successful abortion, etc. So, and also what we observe is that the price of those medicine vary very much, and we had we notice the discourses of pill sellers. Some of them telling, yes, this one I sell $17 because it's 100% efficacy. That one I will sell $13 because I guess that it's 80% efficacy. The people selling those products, they have their own discourses based on their own experience while selling the medicine. And also those products, they are also sold in market from street vendors, from rural practitioners. And also when we did fieldwork here in the karaoke, because we work on some extent on fieldwork, on sex work practices here, this Chinese pill, for example, they were also sold by DJs in karaoke. So there is many ways to get it. So the scope of this Chinese medicine are very much developed. In one hand, the majority of women we met here have already used that pill, and the drug was sold in many pharmacies we visited. And in other hand, there is several practitioners that also had the discourses that since the availability of the wide availability of those products, their practices, their surgical abortion practices were constantly limited. So to go on that also, I published one article in the Mousson related to the karaoke girls, and I refer also to that work of Chinese pill available in karaoke place. So the question then is why the Cambodian women do not use use unregistered abortive pill, despite the legalization of abortion here in Cambodia. Effectively, following the conference of population in Cairo in 1994 and its recommendation in terms of limiting unsafe abortion that are responsible of high rate of mortality, maternal mortality, various international organizations and NGOs involved in the field of health launch activities aiming to provide prevention and post-abortion care. In 1997, the Cambodian parliament passed the first law regulating abortion, and it allowed abortion on request through the 12 weeks of pregnancy and under specific circumstances during the second trimester. This law was mostly adopted as a trial to reduce the maternal mortality. On that time, that was estimated at 900 deaths per 100,000 live births. Now, these days, in 2015, the last figure are about 200 something, so it has considerably reduced. So it was really a way to limit the unsafe abortion procedure. So the law was promoted in 1997. In 2007, 10 years after, the Ministry of Health did not establish yet protocols for safe abortion access. So while safe abortion access is one of the pillars of the maternal reduction program, why have initiatives to improve abortion services in the public health sector been only recently implemented? This is a question. So one of the common facts given to explain the delay in the implementation of safe abortion services in Cambodia is that the majority of Cambodian people follow Buddhism precepts, and for a variety of sources, it appears that abortion is severely disapproved by Buddhism tradition, especially in the ancient Theravada texts. And even if there are various discussions in the Buddhist milieu that I will not mention here, it's generally assumed that abortion stands in violation of the first precept against taking life. But there is other reason also why those services are not implemented, and I think it's very important to extend the scope here. And if we look into who are the donors providing the funds required to develop reproductive health services in Cambodia, it appears that USAID, the United States is the largest donors in this field. The State Agency for International Development effectively is providing the majority of the funds for reproductive health. And as you know, for various integrated moral and political reasons, abortion is still very much stigmatized in the United States. And in this context, what is known the Mexico City policies has a tremendous impact on reproductive health policies. Alors, what is the Mexico City policies? Under this policy, it was decided that the USAID had to stop any activities related to abortion access and to withhold any USAID funds from NGO that use also non-USD funds to engage in a wide range of activities, including providing advice, counseling, providing information regarding abortion, or being involved in lobbying to legalize or make abortion available. So this has a tremendous impact in Cambodia. And what has been called by NGOs the global gag rules, it's a pity because I had pictures to show you about demonstration related to that. It was very much interesting. This global gag rules that was called like this, referred like this by NGOs in 1984. This limitation was reversed by Clinton in 1993, but in 2001 Bush revived this restriction, and then again in 2009 Obama lifted the ban on the US fighting for international health group providing counseling for terminating pregnancies, perform abortion, or promote its legalization. To go further of these issues, I refer to a French text I published in a book about related to the anthropology of medicines in the South, and I can give out to you. So to analyze all of this limitation in terms of law and circulation of biotechnologies, it's very much important to trace all the history of the population control, actually, that started effectively in early 20th century with the eugenics movement and with what has been called the population bomb hysteria in the 1960s. And also then with the old implementation of program in the South. In summary, and here I wanted to refer to a book by Matthew Connelly, The Fatal Misconception, which is the struggle to control world population. It's a very interesting book that gives all the global context on these birth control policies, and it's very much necessary to understand what is going here, actually. So to summarize, in the first half of 20th century, little attention was paid to maternal and child health internationally. In the South, mainly the health initiative was implemented in the field of tropical medicine and had the objective to protect the population in order to provide the colonial administrator an healthy workforce. And then it was only in late of the 20th century that the issues of population explosion in the world became the target speech for various public and private action, national and international level. In the North, the Planned Parenthood responded in part to the right to sexual fulfillment and not hindered by the procreative risk, the claim of women to freely dispose of their bodies. In the South, the birth policies were first initiated in India, in Pakistan, with very coercive measures, as you know, then formalized in the world by creating international organizations like WHO, UNFPA, UNICEF, and various non-governmental organizations in charge of the production of standardized programs. So then, to understand what has then been implemented in Cambodia related to this especially birth control program, it has also to be analyzed within the work that has been done on the interconnection, the negotiation, the intersection in between the biomedical system brought to Cambodia during the colonial period and the indigenous system. And for that I wanted to show the book I was referring on three books, the book of Anguillu, related to the doctors in Cambodia from an historic perspective. There is also for sure the work of Tronkel and Overson about doctors also, and then this history of the emergence of the biomedical system in Cambodia, and also So Kyang Ho, the book of So Kyang Ho, Mixed Medicine, has very much investigated the intersection on the two systems of medicine, indigenous system and biomedical system. So to come back now after this broad issues, to come back, what is going on now with these abortive pill issues? And I want to speak now about the registered abortive pill, the Medabon. since the launch of the Millennium Development Goal, you know, les objectifs du millénaire pour le développement développed by the WHO, among these various objectives in various fields, there is the goal number 5 and 4 that are to reduce the maternal mortality and the child mortality. So in this field, many actions have been implemented in Cambodia, and effectively, there have been a very strong commitment of the government to manage to very much reduce this rate. And within this program to reduce the maternal mortality, various abortion programs have also implemented. Sorry, I need to have some water first. So, among those programs, there was many programs, particularly in provincial hospital, to train medical practitioners to perform surgical abortion, but also there was a work launched by different organizations here to get the authorization of one registered abortive pill here in Cambodia. And it has been, and on that time, from 2008 to 2011, I was involved actually in those working group with Maristop International, PSI, UNICEF, etc., that work very much to get that pill registered. And finally, the pill was registered in December 2009 and was provided first in provincial hospital level, in some registered pharmacies, and was also available in some clinic of NGOs as the clinic of Maristop International. I don't know what time is it. I don't know if I have to go on those details. Yeah, it's okay. And on that time, one of my research here was to document what is going on also with those metabon pill. So we published a paper on that. It is published on Reproductive Health Matters, so I can just summarize, and you can easily get access to this paper too. So it was a small qualitative study that I integrate mostly on my longer-term ethnography on birth control issues in Cambodia. And what we observe is that in Cambodia, so the medical abortion products are available in various settings, and this raises different issues for public health programming, because we observe that women who do not have access to medical abortion in health institutions can get metabon also through a registered pharmacy, and where in those pharmacies the medical abortion pills, the sale of this medical abortion pill is combined with counseling, patient follow-up. That means that even in this small pharmacy, some pharmacies, they are doing the work to follow the women. And for sure that the NGO side, as there is much more training of the staff, much more organization, the staff are much more knowledgeable on the protocol, the side effects, etc. But at least the issues to train the pharmacies to give very good services when they sell the drug has to be considered. Also, the evidence of the safety of medical abortion regimen is very well documented widely, and it was what was documented also. The acceptability of metabon was very good. And what was interesting is that what came out in the study is that the abortion is not all the time an only women business. And we interviewed also some men on these issues, and it's in light their sensitive concern also, and sometimes even they were given supportive roles in this process. For sure, these findings maybe have to be viewed cautiously because we also in the other part of the field work, we know also of many women manage also their birth control practice by their own, do not always inform their husband about their decision on that matter, on the decision of having an abortion and how to obtain it, etc. The last part of my talk is related now. I want to go deeper in this analysis of medicine and to trace the different actors actually involved in this medabon production, circulation and distribution. Again, it's a pity that I do not have this slide. Because it could be so helpful to give a clear picture. So, what you have to know is that the drug has been designed by Concept Foundation. What is Concept Foundation? It is presented as an international non-governmental and non-profit organization based in Bangkok, Thailand, Geneva, Switzerland, and supported by various donors, including the USAID agencies. This Concept Foundation works with Sun Pharmaceutical Industry. Sun Pharmaceutical Industry is located in Mumbai, in India, and there have been a creation of the Public-Private Partnership, PPP, in which Concept Foundation was able to provide clinical and pre-clinical data required for an internationally compliant registration dossier. So these two are working together within a special program for research, development and research training in human reproduction, funded and supported also by WHO. Then, this pill is sold by PSI here, Population Services International. You know, it's a big organization also, which is based in Washington and has various programs in 69 countries. So PSI here utilize another actor, which is Mega, that is a pharmaceutical distributor present here in Cambodia, to make Metabon available in different places. PSI can sell the product to Mega to a very lower price, thanks to the support of the Susan Thompson Buffet Foundation, that has a program within maybe you know the Giving Pledge. You know, the Giving Pledge is a foundation also supported by Bill and Melinda Gates and by Mr. Buffet. It is a philanthropic campaign where wealthy individuals agree to give away at least half of their fortune to provide different support. So PSI can sell abortive product in Cambodia to Mega in a very low price because they can get additional funds from this Buffet Foundation. What we observe in our fieldwork is that in March 2013, Medabon was still a very sensitive issue because it simultaneously faced a high public demand, as everybody wanted to buy the product. There was a rupture of stock, and in the other hand, the hesitation of Cambodian authority to meet the will of some international organization in distributing the product widely as possible. According to the abortion law, the registered abortive pill could only be distributed in certified institution, and it could be made available in private center nor in pharmacies, which actors do not have other option than to sell the unregistered pill. So it's very complicated, because even if the registered pill is there, there is the law, etc., but still there is many limitation. In 2012, Maristop International, who could not get enough metabon pill, decided to register another abortive pill, which is Mariprist. And I tried to trace what is Mariprist. And if you have some information in Mariprist, I am very much fond of it, because I just see that Mariprist, the exporter of Mariprist, are located in India, but it was very difficult to understand who owned the pharmaceutical company behind this Mariprist. So as you see, this small pill can lead to many kind of direction of an analysis. Just to finish my presentation, few words on Laos. Now I am based in Laos for IRD since more than 2 years. I am not working on abortion. I cannot really much work on abortion unofficially, as research in Laos is very much under control, so it's not possible. But through my work on ongoing on human reproduction issues, I got some data on that. So in Laos is very different, because we are in the context where there is no law on abortion, but abortion practices are provided in various sectors, by private and public also, and abortive are available. I wanted to show you the picture of how to look what is the conditionment. I don't know comment le conditionnement, the package of this abortive pill in Cambodia. It is also the Chinese pill, and it's very interesting to see that this Chinese pill in there, and the women know they refer it as Xinia, the medicine from China. So to conclude, so this work goes in this kind of analysis of the globalization of biomedical technology. As you saw, it's involved many actors, and with the intensification of transnational exchange since the mid-20th century, it has very much contributed to the global diffusion of these biomedical technologies, but also it shaped their history in various ways that the anthropologists interested in documented all these medicine and biomedical product can trace. So thank you and for coming, and I can take some questions if you like.
Thank you very much. I don't know if can you hear me?
Yeah, I can hear you. Yes.
I was not in the first 5 minutes
yeah.
when you started, so I have 2 questions.
Mm-hmm.
First is this abortifacient pill combination on the essential drug list of WHO, and second, you mentioned something in your last few minutes about another medicine that Maristop's Cambodia was trying to get into the market because it couldn't get the other one, which was out of stock. Is this the same medication, but generically, but only under a different name?
Okay, alors yes, Mariprist, the second drug that Maristop want to register, is the same. It's the combination of mifepristone and misoprosol at the same dosage, because WHO they have a standard, so it's very much clear standard of how many milligram of each molecule the tablet has to contain, how many it has to be taken, etc. So there is a kind of international standard protocol. we cannot say that it is in the essential list of medicine. It's something else, the essential list of medicine, but it is a registered product. So this is very important, that it is not an illegal medicine. It's very much, and it has taken years, because the law on abortion in Cambodia dates on 1997, and the product has been registered in 2009. So it's very, very long process.
And is the Chinese pill that you mentioned the same?
Alors, the Chinese pill, when we did the fieldwork here, the issue is that there is many kind of Chinese pill. Many kind of. And I have the pictures here. I never worked on that, but I should ask somebody to translate also all the paper in it. And the issue is that the women, they buy this Chinese pill. They are not at all allowed mostly they are not able to read what is written in the box. I guess that the pharmacies, they are not always allowed to read what is in the box. And so it is the problem with the Chinese pill medicine. Perhaps some of them have the right dosage of misoprosol and mifepristone, maybe. But as it is sold in illegal market, there is no trained people that are able to give the right information to take it. And it's very interesting, finally, to wonder why the product that is registered is a product made in India with the Concept Foundation through the government, rather than we could imagine that there could have been also some regulation with China to make the Chinese pill registered. So it is another, things to go through, with this, finally the competition of pharmaceutical companies, what has to be analyzed maybe in higher level of decision to understand how the people choose, some way to go for the registration of medicine or not. No, they sell many kind of medicine, and they sell that one too.
Because they are really mobile seller.
Yes. In fact, I refer it as a street sellers, but the exact data is a seller in their bicycle in the village, and they have many kind of medicine, and they have also the abortive pill. But where it was in urban setting or in village? But since when? Yeah, but so the people, they told you that they were not anymore street vendor, but since recently? Since 2-3 years. Oh, it's very interesting. Yeah. Ouais. Yeah, it's very interesting because this field work, I did it in 2008 to 2012. So yeah, it's already 3 years ago. Yes, it's very interesting. Yeah, very interesting. Thank you.
I'd also like to share that what you mentioned about the Chinese pill is not. I mean, it happens for many different kinds of medicines, especially oral contraceptives. One popular contraceptive that we did a little bit of work on was called OK.
Mm-hmm.
Yeah, it's an oral contraceptive pill, and it's used by